webinar for February. Real quickly, I'll share that these particular webinars are designed to provide a quick 30-minute overview on a variety of different chosen topics. If you are a person with a disability, a family member, or if you support someone with a disability, welcome. We're very glad to have you on board. If you're someone who works with families and individuals, please be sure to let them know about these webinars. Also let folks know that if they can't participate in one of our live sessions, they can always go back, excuse me, as Kat shared, they are recorded. They can go back to the webinar page and listen to the recording later. For today's webinar, we're going to start off with introductions. We're going to introduce ourselves so that you know who we are. We're going to give you a quick update on where the division currently is on implementing the HRST. We're going to talk about why HRST data is important, and we'll discuss the benefits that can come from using a HRST. Have a lot of information to share today in a short period of time. So without further delay, I'll just go ahead and start off with our introductions, and then I will hand it over to Leslie and Jonathan. And Leslie and Jonathan, I just want to tell you both thank you real quickly for coming on board and joining this webinar today. I think this is a question that a lot of folks have. We're hearing about HRST throughout our division, support coordinators, different teams. Not really sure what we can expect exactly. So from a family and individual perspective, I'm going to really be leaning in on you guys to help provide that glimpse of what we can look for. So I am Lisa Nothouse. I work for the Division of DD as the Supporting Families Lead, and I am also a parent. My youngest daughter has a developmental disability and she receives related services. And it's because of my daughter that I've been involved or have worked in the DD field for a little over 30 years now. So I don't know if that makes me old or just makes me seasoned, but I feel like I've been around the block a few times. I'm going to go ahead and turn it over to you, Leslie and Jonathan, and you guys can introduce yourselves and begin to share your information. I think, Leslie, you're going to share your screen, and then we'll come back at the end and wrap up.
I'm trying to talk on mute. Thank you, Lisa, so much for having us here today. It's a pleasure to be able to talk about the health risk screening tool and to just let you guys know what to expect. And always, always at the end, I'm going to put an email address at the end. And I want you guys to feel free to reach out to that email and ask any, ask questions, what have you, but hopefully we'll be able to answer some questions today. I'll share my screen in just a second. I guess Jonathan's showing his face, so I don't necessarily need to show his picture, but I do want to introduce him. He's a very valuable team member, and he has lots and lots of experience with the health risk screening tool. Give me just a second. He's the Chief Operations Officer for the company Intellectability, which is the company who created the health risk screening tool, or HRST. But prior to that, he started working in the field of intellectual and developmental disabilities in 2002. He has been the former Vice President of the Georgia Support Services. He is a former SIS trainer for AAIDD within the United States and Canada. He's also certified by the learning community as a person-centered thinking trainer, which is very exciting. And you'll hear more about person-centered thinking as time goes on. And as I said, he's currently working with the Intellectability company. He also worked as a support coordinator and utilized this health risk screening tool with individuals with supports in the state of Georgia. So he's just a wealth of knowledge and has valuable information to share. Now I'm going to go ahead and share my PowerPoint. Bear with me. I'm kind of clunky sometimes. Okay, can you guys see my screen okay? And on this slide, I just kind of put up some questions that were really pretty common. The division made the decision to utilize this health risk screening tool in order to help people with both residential services, or they have that oversight RN presence there, either utilizing it there or with non-residential services, just so that we can do the best that we can to help individuals be able to live happy, healthy lives and help you guys identify support needs that will make your lives easier and healthier. So some questions that we thought, how can the Missouri HRST process help? What can individuals and families expect with a HRST? Well, Jonathan is here today to answer some questions on this. So it's going to be kind of an interview type format. If you guys do have any other questions that aren't covered or that just come up while you're thinking about it, please definitely drop in chat and we can look at those and use those for our frequently asked questions pages. So without further ado, Jonathan, how are you doing today?
Great, Leslie. Thank you. Very nice introduction, by the way. Thank you.
Oh, good. Well, we appreciate you being here with us today. Do you mind speaking a little bit about your first encounters with the health risk screening tool and just kind of give us a little talk about that when you used that back in the day?
Back in the day is exactly right, because it's been like 20 years ago. And Lisa, by the way, over 20 years in the field, I prefer seasoned like you do. That's the best way to describe it. I should apologize. You'll hear me clear my throat a lot. I live in Tampa, Florida, and you guys have probably not started experiencing the pollen in your area, but it's in full force here. So we're all kind of congested and riddled with postnasal drip. So you'll have to excuse me. I may have to take some water here in just a moment. But yeah, so I was first introduced to the health risk screening tool back in Georgia around 2002, early 2000s. Georgia had been using the HRST for a few years before I came into the field. And by the time I came into the field, Georgia was training up support coordinators to be the raters or the administrators of the health risk screening tool. So when I came in as a support coordinator, I had no clinical experience, knew nothing of the field of intellectual and developmental disabilities. I had just graduated from graduate school in a completely different field and was really just taking this job as a placeholder until I could pursue a career more in the educational path that I had chosen. Ended up getting in the field, loving it, and now 20 plus years later, I'm still in it. But one of my first encounters with the HRST was as a support coordinator. Georgia was rolling it out to all of their waiver participants. So anyone receiving waiver services on either of Georgia's two waivers was expected to have an HRST screening. And really what Georgia was trying to do was get a better handle on the obvious and the less obvious health risks that folks with intellectual and developmental disabilities had, so that they could go in and do some more preventative work to keep those risks from emerging and becoming acute illnesses and more life-threatening conditions. So I was trained as an HRST rater in the early days by Karen Green McGowan, who is the founder of our company and the actual creator of the HRST. And back in those days, it was all live training. It was not the online training that we have today. But that was my first encounter with the HRST. And so I would go on as the years would progress, working as a support coordinator. I would serve as a rater for many, many years, and would use the HRST in my day-to-day maintenance and managing and overseeing the health and safety of those on my caseload, would use it to help build out the individual support plan every year. And it was really a focal point of conversation between the support team on where the person was showing risk and destabilization and what the team could do about it. So that's my first introduction to the HRST. And then now 20 plus years later, I've been working either directly or indirectly with it. And now I work with intellectability. So that's kind of in a nutshell, my first introduction to it, Leslie.
Well, thank you. I think you already answered this next question, but I was going to ask, did Georgia roll out to all of their waiver participants? And you did answer that, not only residential, but we've had the health in I can't think of it, the HIPS process in Seymour, where we would use that to identify risk for residential waiver participants. Well, really, it's only fair that we share health risk screening with all of our waiver participants. So that our division decided to adopt this so that we can just do the best job that we can for individuals who we are supporting. One question I have here, or what are some things that you would share with individuals and families about what to expect when completing the HRST screening?
Yeah, that's a great question. there's a lot to be said here, so I'll try to condense it down and not take up the whole 30 minutes on this one question. But what you want to remember is that the HRST is a screening tool. It's a questionnaire. It's not an assessment. It's not meant to be an in-depth assessment. It's primarily meant to be a screening tool that can be administered by a non-clinical person, which I'm proof of that. I used it for years, and as clinical as I get is advanced biology and chemistry from high school and college. That's about what you're going to get from me. So I'm living proof that a person with no clinical background and no pre-existing exposure to people with developmental disabilities can serve as a very much an adequate rater. But it is essentially a questionnaire. Oftentimes in training, our trainers will equate it to this. If you've ever been in a CVS or if you've been in a Walgreens, and you'll notice that many times there are these unmanned blood pressure stations there that you can sit down and put your arm through the cuff, right? And it'll get your weight and your BMI and your blood pressure and your this. And what it's doing is simply screening you, right? And when it gives you the results, it'll tell you, hey, you're in range here, you're out of range here, you're in range here, out of range here. And so what you can do after you get those results is you may decide, okay, you know what, my blood pressure is really higher than it should be. I need to go to the doctor and get a further assessment or a further evaluation to see what's going on, because maybe I'm at risk for something and I need to treat it early as opposed to waiting. Well, you can think of the HRST as a version of that machine that you sat down. Through asking questions and through answering yes or no questions, what the HRST is looking for is indicators that show that the person is at risk for certain things that we may not be aware of, because a lot of these risks, particularly with this population, do not manifest visually. So people with intellectual and developmental disabilities are at a higher risk of destabilizing silently because they may not be able to use words to communicate, or they may be trying to communicate it, but it's coming through as a behavior. And we're interpreting the behavior as a psychiatric issue when the person is actually trying to tell us, I'm in pain, something's different, something's wrong, I don't feel well. It could be a number of different things. So what the HRST is doing by asking these yes or no questions over these 22 rating items is simply looking for things that just aren't right, that are out of place. I'll give you a great example. One of the questions that is asked in gastrointestinal will ask the family member or the support team, does the person engage in eating inedible objects? Do they chew on things that aren't edible? Have they tried to swallow things that we normally just don't eat? Well, now, if someone answers yes to that question, what the HRST knows is that that behavior is directly related to upper GI distress. So when people are eating paper, when they're eating cigarette butts, when they're eating napkins, when they're eating things they're not supposed to, more often than not, what the person is trying to do is satiate or calm the burning in their esophagus. So when you have folks that are chewing on rags a lot, or they have oral fixations, what they're trying to do without being able to tell you this, it's all manifested in the behavior, is generate more saliva to coat the esophagus to ease the pain a little bit. So the HRST is going to ask, is the person do this? Do they cough after meals? Do they become upset or agitated after meals? And if these questions are yes, the HRST is going to say, hey, you may not know this, family member or support team, but what this person is experiencing is directly related to GI issues. You would want to get this person seen by a gastroenterologist to rule out that the person is not experiencing esophageal reflux disease or a number of different things that can cause pain. And if you've ever had heartburn out there, you know it can almost feel like at times you're having a heart attack. Well, imagine if you could not verbally communicate that to someone, what's going to be your go-to in terms of trying to get somebody's attention? I have a great story about this. There was a lady that we supported in Georgia that she was known as the lady that would chew on a towel and then hit staff with it as they went by. And so she had been known for years, and the team just thought, well, I guess this is things that people with intellectual and developmental disabilities do, you know, as though that's normal, right? To chew on a rag or a sock and try to hit somebody with it. But they had seen it for years and just chalked it up to, well, this is what people do. It was only until the HRST was administered and those questions were answered yes, the team realized that we should probably have this lady seen by a gastroenterologist. And they did. And as it turned out, this woman, this poor lady for years had been suffering in silence with GERD and heartburn. And it was even to the point that it was now beginning to show early signs of esophageal cancer that was starting to, she was on a bad path. So what they did is they began treating that. And when they did, obviously the pain went down, and with it, the behaviors went away. And this lady was transformed. Her life went from being someone who was suffering. And as it turns out, what she was doing was taking that sock and chewing on it to generate more saliva to coat the esophagus. But when people would walk by and she would try to hit them with it, what she was trying to do was communicate, hey, I'm in pain here. Chewing on a sock is not normal. Can somebody help me? And yet for years, people just thought, well, this is just a behavior. So I can't tell you how many of those stories are repeat stories that we hear, because what the HRST is trying to do is get to the root cause of what's causing the issue. Another thing, Leslie, that where we see this is in seizure activity. For example, folks may have had their seizures controlled by medications for years, and they haven't had any seizure activity. But here's what we know that most people may not, and that is as you get older, seizure activity can return, but it oftentimes does not return and look like it did in your younger days. So the person's been seizure free for years, they're getting older, and then all of a sudden out of nowhere, they start manifesting abnormal behaviors that are not characteristic of them. Now, the knee-jerk reaction of all of us is typically behavior, we need to treat them with a psychotropic medication. When in fact, what we're actually seeing is a reemergence of seizure activity. And really the person does not need a psychiatrist, they need a neurologist to go and do a new evaluation of their seizure medications and rule out that this is not seizure activity. So in the rating item of seizure, when those questions are answered, if the questions are answered in such a way that the HRST feels like that this person may be having new onset seizures that are manifesting in a way that they have not historically, it's going to recommend to the team, hey, you probably should have this person seen by a neurologist because of that very thing. So those are just two examples of what the tool is doing. It's trying to screen the person, look for those red flags, and then turn around and give the team or the family kind of a roadmap on, hey, here's what we're seeing. What we're seeing may not be visual to the eye, but it's being detected. And here's some actions you may want to take in order to address this before it gets any worse. Now, I can't leave this question without talking about the healthcare level, because when the HRST is fully screened, it's going to generate a healthcare level, an overall healthcare level, right? And these healthcare levels can be 1 all the way to 6. 1 is very low risk, meaning the HRST is not detecting a lot of risk and destabilization, all the way up to 6, where the HRST is maxed out. It is, the person is destabilizing in a number of different areas, whether the team's aware of it or not. Now, what we know about these healthcare levels is that study after study that the HRST has been a part of, the HRST is capable and it's prognostic of predicting early death based off these healthcare levels. So as the healthcare level increases, the risk of early death increases with every healthcare level risk. In fact, the person's odds of dying with just 1 increase in healthcare level go up 54%. Okay, so when we think about what it takes to move a healthcare level, if you're moving a healthcare level up a notch, that means that across those 22 rating items, enough destabilization and risk is being detected that it's able to move this person into a completely different risk category. And what we see is in study after study, and most recently was out of Georgia, the Georgia Annual Mortality Study, was that as healthcare levels increase, the odds of dying increase. Now, the sad thing about it is that more often than not, what people with intellectual and developmental disabilities are dying from is preventable. It is 100% preventable. Not in every case, but in the majority of cases, people with intellectual and developmental disabilities are dying of things that if we had known about and appreciated early and treated root cause, the person would not have died. And so I have to make sure I talk about that, because the average age of people with intellectual and developmental disabilities, their average age of death is 54.25, I think. And I don't know about you guys, but if you're on the call and you care anything about this population, you believe like we do that that's completely unacceptable. People with intellectual and developmental disabilities should be living longer than 54. And if you're on the call today and you're anywhere near that age, like I am, I'm 47, then that is a bit of a wake-up call, right? Because we're like, my goodness. But so those are some key things that I would want anyone on the call to hear, is that it's a very easy questionnaire, but the power of the tool to recognize and provide actions that prevent death and prevent suffering cannot be overstated.
Wow, thank you so much for sharing all that, Jonathan. Yeah, that's very important information. It looks like we're closing in on the end of the half hour, so I do want to squeeze in a couple things beforehand. Lisa did drop the link to our website in the chat for people to go in and look at it. And I did want to show you resources. And I did want to tackle one more question. It's, if I'm an individual with a disability, what can I expect to happen, and how long will a HRST screening take?
Yeah, it's a great question. What you can expect to happen is for the rater to come and ask you a series of yes or no questions. And these are very simple questions that you might expect your doctor would ask you if you went to the doctor or I went to the doctor. You know, has the person had any falls in the past 12 months? You know, have they had this or have they had that? Or, you know, bowel habits, things of that nature. And the questions are very high profile. Anyone who knows the person should be able to answer yes or no for the rater to say. And if the rater, if they're not able to answer and more data needs to be gathered and come back, the HRST can always be updated, you know, in real time. So, but those are the kind of questions that the team will be asked. And it's an interview kind of style. It's very laid back. There's no need for any questions about anything that's like super private. Again, these are the same kind of questions you want any health care professional to know if you were going to the doctor. So we're not interested in collecting any kind of private information or, you know, sensitive information or anything like that. The screening doesn't require that. It doesn't require that. It's not an intrusive thing. It's just needing to know the answers to some questions to be able to determine what the risk level is in that particular item.
Thank you. And I just want to add to that too, for those who have residential waiver services, the RN who provides oversight will reach out to you to schedule that screen. And then for non-residential waiver services, your support coordinator will reach out to you and schedule that screen. So it's just kind of, it's individualized, and it's kind of up to, you know, individuals and family and those who know them well to complete it. It's kind of a team approach, you might say. So I just wanted to throw that in there as well. And then Lisa, did you have any burning questions before I move on to show? I have another slide for contact information that we can have, and then just show them what the website looks like. But
I just had I think we touched on the questions. Leslie and I were shooting questions back and forth before we started the webinar today. So you've done a very good job of explaining it, Jonathan. I appreciate you coming on board and sharing that with us. I like the idea with the blood pressure cuff. That makes a lot of sense.
Right.
How often is a HRST completed with folks? Is that going to be on an annual basis? We're going to develop a baseline, and then are we going to do it annually, or how often will that be done?
Yeah, so that's exactly right. What you want to do is think of it as an annual checkup. right? At least once a year, you want to have a screening done, review the scores to make sure no additional destabilization or risk factors have been introduced over the past year. But always, the HRST can always be updated at any point the person starts to show signs of destabilization. So if throughout the year, the person starts falling more, we want to make sure that the HRST is updated, because that may be an indicator of something else going on that the HRST can jump in and say, hey, you may want to have this checked, you may want to have that checked. So we think about it as a minimally annually, but as the person shows signs of destabilization where scores can be affected, that rater would want to come out and readjust and update the screening. And by the way, I don't think I answered the other question about how long does it take. The first screening usually takes, it all depends on how complex the person is and how clinically complex they are or behaviorally complex they are. But generally, the first screening takes anywhere about an hour, maybe a little over an hour. It can vary. But then going forward, just to keep the HRST updated and change scores as needed, it's a matter of minutes. I mean, it's just a matter of re-answering some questions to get a new score, and that's pretty much it. So it's minimal investment of time for the interview.
So I really see this being a benefit to folks who maybe are new to the residential placements idea. So somebody who may have just moved out of their family home and are living on their own, or are living in with another residential situation, but having that family history so that it doesn't get lost over time, having the families involved in the HRST process I would see being a tremendous benefit.
Most definitely. Yeah. Anytime the family can be involved, it's an added benefit, because you want the HRST screened and scores determined by folks who know the person best, right? Who see them in different environments, who spend the most time with them, because direct support professionals and families are going to be the first to identify that something's just not quite right. They might not be able to put their finger on it, but he hasn't acted like this in the past. He hasn't grimaced like this in the past. This is not normal for him or her. And it's going to be those frontline staff and family that are going to know that and appreciate it. And what the screening tool is trying to do is look for the family that may not have a clinical degree, and for direct support professionals that may not have a clinical degree. The HRST is trying to bridge that gap and tell us what we just don't come to the field knowing, because the HRST is packed full of decades and decades worth of learning about how people with disabilities manifest risk and where they are at most risk. And that's knowledge that families don't have, and many of us who come to this work do not have. And the tool, though, is compensating for that. So as long as the team can accurately, or as to the best of their ability, answer those yes or no questions, the tool will take care of the rest and get you an accurate enough score that you can determine where risks are present or not present.
Yeah, very important, very important. And I know, speaking from my own personal situation, I was amazed. I was telling Leslie, and I have talked about this before, when you see all those health risks identified, and knowing that the individual that I support has more than one of those, and that raised the red flags even higher.
Sure.
Just having that information as a family, because some of that stuff is what we've known for so long, but not realizing that it was as maybe a critical factor,
Right.
as what it could be. So yeah, and we've not been down this road before, so we're aging right along with her. We're all going through the journey together. So having that information, I think, is really important.
And to be able to have information that you can hand off to the doctor, right? That says, hey, because doctors are aware of screening tools. That's part of their world. They know those. So if you go to the doctor and say, hey, we do a screening tool, and this is where my son or daughter is showing risk, and the HRST even gives handouts that you can take to the doctor who may not have any training on supporting people with intellectual and developmental disabilities, which, by the way, currently in the US, med schools are not required to have criteria on how to treat people with intellectual and developmental disabilities. So the majority of doctors out there, though they're trying to do their best, they don't have training with this particular population. So the HRST gives a handout that says, hey, my son or daughter shows risk in this area, and this is what you as a physician need to know about that. in relation to the person having developmental disabilities. And it's a little one-page document. The doctor can quickly read it and get oriented to how this risk manifests in people with intellectual and developmental disabilities. And the hope is if that's a good doctor, they'll take that information and then act on that. So it becomes a tremendous resource for families when they're actually visiting and taking the person to the doctor.
Absolutely. Absolutely. I agree with that. And then, like you said earlier, I think you mentioned that, the score becomes part of the planning process.
Sure.
And from that point, you have a learning curve where you learn how to help mitigate those health risks. So thank you very much. Lots of good information. And it looks like we're a minute over, or 1 o'clock. We won't keep folks much longer, but I do see that there are some questions and comments in the chat that I don't think we're going to have time to get to, but we will gather those up and make a Q&A document to go with this presentation. And Leslie, if you will go ahead and go back to the original PowerPoint. I'll just thank you guys both for coming on board.
Sure.
Again, good information. And for the next Mo DDD and U webinar, mark your calendars, March 28th, 12:30 to 1. Thank you all so much for coming. Thanks, everybody.
Thank you, Lisa. Thank you, Jonathan. Thank you, Kat. Everyone have a great day.
You too.